That was the biggest controversy when fecal transplants gained popularity in the media, I would say, by the end of 2012. I've been doing fecal transplants since about 2009, and I'd heard about them in 2001 when I was still in college back then. And I think the biggest thing that turned people off, the thing that put a bad taste in their mouth, if you will, is the aesthetics of it, you know? I mean, but part of this is humor, right? So if you're a chronic C. diff patient, and you're sick and tired of being in the hospital and antibiotics and IVs, etc., those are the patients who, the majority of the time, the aesthetics of it won't bother them. The biggest thing in educating the patient, empowering them, is not using a lot of verbiage and just calling stool what it is, poop. You know, talking in regular language, which is hard for a lot of doctors to do, and explaining not just the risk but the benefit. So it's a good informed consent, a good honest conversation about what it is that they're ingesting and putting it in clear layman language that will get them comfortable with it. I'm trying not to laugh right now, but I'll tell you that there's an abundant amount of stool, sure. But the resources to responsibly, to financially screen these patients, not just their serum and their stool, but clinically that they're a healthy individual, it's those financial resources that are lacking. Now, on the whole, many of our stool banks, at least one of them in particular that we've spoken about, have done a wonderful job of keeping cost down. And ultimately, the cost of those stool transplants is very inexpensive compared to the cost associated with these very expensive antibiotics that we prescribe patients in refractory cases. I think, you know, part of the problem is not enough money and not enough insurance coverage. That's another big thing. Not enough insurance coverage for something that's so efficacious, overwhelmingly efficacious, which is a big challenge for us to get insurance companies to reimburse. If insurance companies could get on board unanimously and reimburse for the donor stool collection or processing, even stool banks, it would go a long way. Because it would not only prevent the patient from having to get expensive antibiotics, it would prevent very expensive hospitalizations and mortality. I think it's what they call experimental. You know, there's only one insurance company to my knowledge that, as of 3 years ago, had put out a statement on their website saying, we know this is experimental, but we will reimburse and cover you know, the cost of the donor specimen, and all the other insurance companies are just waiting to see what happens. You know, if there's a CPT code for it, etc., they're waiting for, you know, reimbursement rates to apply. But until then, as long as it has the word investigational or experimental on it, it's not going to be covered, which is a real shame. Because we're wasting money, billions of dollars on antibiotics and unnecessary hospitalizations. So there's a lot of things going on in the world of IBD and fecal microbiota transplantation. You know, the studies with Crohn's disease have been very, you know, not very surprising. Either no effect or in some cases a flare of their existing colitis, which kind of makes sense because you're altering the microbiome. We know that has some interaction with the immune system. In ulcerative colitis, the tides have changed a little bit, but not enough where we can make a recommendation for transplant in UC. 2 studies came out this past year of 2015 that demonstrated, one demonstrated statistical significance of fecal transplants for ulcerative colitis, and the other one trended there, but there was some issues with the study where they couldn't power it just enough to give it statistical significance, but one was definitely statistically significant and the other was close. So we have some data to suggest that this can help, but a word to the wise. You know, we get a lot of consults, both in and outpatient, especially for fecal transplant for UC, and you know, we've seen patients flare uncontrollably where they need the steroids temporarily to get better. So we really discourage it, and you know, from being practiced until there's more high-quality available data. And then, you know, other indications for fecal transplant, which are areas of research interest right now, is irritable bowel syndrome, that is diarrhea predominant, right? Next evolution from C. diff. So there's at least a few international trials going on, at least one that's being performed domestically here in the United States. These are randomized, placebo-controlled trials, the placebo is either fake stool or autologous transplantation, where the patient actually gets their own stool, just doesn't know it. So rather very interesting designs that are going to help elucidate whether FMT can help in IBS. And there is some data to say that it may help in constipation too, but again, very, very early clinical trials.